the first presentation, and then we will follow with case presentations from two fellows and also from me if there's time. Abhaya is currently professor of surgery at the University of Toronto and vice chair culture and inclusion in the Division of Neurosurgery at the university. At the hospital, he's associate chief of surgery in education. Abhaya's clinical and research interests are in the management and clinical outcomes of patients with hydrocephalus, and I think many of you should be familiar with his trailblazing work over the span of the last 15 years in this area. So I think it's a privilege that he's had the time to present to all of us today. So without further ado, Abhaya, please start your slides.
Great. Thank you so much, Peter, and thank you, Jeff, for having our group host this session. So I'm going to talk about challenges in hydrocephalus management, and it's a bit of a different talk than I usually give because there won't be a lot of science or data or evidence behind this. And as I was thinking about how best to structure this, obviously there's many challenges in hydrocephalus that we could talk about, and in half an hour, what I've decided is just to cherry pick a few points that may be a little bit controversial, that may spark some discussion, and that just may be of interest to the fellows and soon to be pediatric neurosurgeons in the audience. So we'll talk about ETV in babies and some of the considerations that go into that. Then I'll talk about ETV decision-making in older children and sort of pushing the boundaries of when to do an ETV in some older kids. And then completely unrelated, we'll talk about determining shunt independence in older children as well. And as I said, this is not going to be really evidence-based. It's going to be more experience-based, where I'm going to talk about a personal approach to these things. And so that's obviously subject to a lot of discussion. And I will just reiterate it, it's one person's approach, and there are other ways to do these things. So we'll start with endoscopic treatment in babies. And, in general, we start off with acknowledging that ETV alone generally has a poor outcome for many types of infant hydrocephalus. And we can start with the ETV success score because, of course, what else would I start with here? But aside from, using this to prognosticate about an individual child, if you look at it in general terms, what you learn from it is that the overwhelming importance of age and how prognostically important older age is. You also learn that, when you think about infant hydrocephalus, even though, you can get a score here of 30 if you're under 1 year of age, most infant hydrocephalus that we see that we end up treating tends to be under 6 months of age. And so they're in this really lowest prognostic category. And then when you go to etiology, in terms of what's typical in North America, most of our infant hydrocephalus is myelomeningocele and intraventricular hemorrhage or prematurity, which are not in the most favorable group. So you put that together, and the majority of infants that we see are in the low range of predicted ETV success. However, there are data that show that there may be more favorable subgroups of infants for ETV, and one example was from the International Infant Hydrocephalus Study, which prospectively compared ETV and shunt in infants with pure aqueductal stenosis. So this is a limited group, right? It tends not to be a huge group in the population that we see, but nevertheless, in pure aqueductal stenosis, infants under 2 years of age, these data showed that, yeah, shunt does have a better survival than ETV, but it's not tremendous, one could say. But more important than that is that it dichotomizes by age. And so if we go to that 6-month cutoff, those who are under 6 months do substantially worse with ETV than with shunt. But those who are over 6 months but still under 2 years, you can see here that there's not many shunted patients in this group, but nevertheless, the ETV group has a very good success rate. So it suggests that there are subpopulations that can do well with ETV alone. And then the separate issue that we have to consider now is about the addition of choroid plexus cauterization. We know largely from Ben Worf's work in Uganda that it can potentially improve the success rate in a wide range of infant hydrocephalus scenarios. Now, this is Ben's work from his Boston experience. And I'll concentrate you on the solid blue line, which is the primary success rate of ETV CPC in his hands, which is about 50%. When he reoperates on a population of these who fail, then he's able to salvage some of them such that the freedom from VP shunt is on the order of close to 70%, which are very good result. And at least in his center compared very favorably to quite poor shunt results. There's other data, again, for the purpose of this talk, I won't go over that right now because I don't think that's what our time is most valued today. But there's other data from other centers on ETV CPC in North America that are not as promising as this, but this is a benchmark nevertheless. So if you take that data, right, and you sort of digest it, the way that I look at ETV in babies is to consider these factors, right? You look at the age, and older is better, even within that restricted range of babies and infants that we're talking about. Older is still better. And I point this out because the timing of surgery here is an important consideration. You know, many times when infants present with hydrocephalus, it's not often the case that they present in extremis and you have to operate in the next day or even the next week. Sometimes, so there's somebody whose phone is not on mute. If somebody could mute, please. Most infants don't present in extremis. And so when you see them, many times it is a situation where they've just sort of passed the threshold for treatment. You know, they have a large head, ventricles are big, fontanelle may be a little bit full, but they're otherwise doing well. And at that point, I have a discussion with the family and I do tell them that, yeah, you know, your child meets threshold for surgery and I'm happy to proceed and here are the options, but we also have the option of waiting. And what I tell them that is that the potential benefit of waiting is not really expecting that you're going to avoid treatment for this, even though in some rare cases you do because things do stabilize. But more is that as you wait, if you have the ability to wait several weeks or ideally several months, that does put the child in a better prognostic category once you treat. And in particular may make endoscopic treatment more palatable and readjust that risk balance between the two. So that's a consideration. I'm not saying you should always do that, but that's something I think should be in the treatment discussion. The etiology, of course, you have to think about, and pre-IVH and post-infectious, we know do poorly, and that weighs heavily in my decision-making. Having an obstructive lesion seems to do better, particularly pure aqueductal stenosis, and maybe to some degree a fourth ventricular outlet obstruction. The anatomy is obviously important. We want a thinned out floor that makes it nice and easy to do the ETV. And also to look very carefully on the sagittal Fiesta and CIS images to ensure that there's no or very few prepontine adhesions. And then as a sort of a separate discussion in my own mind is what the benefit and risks are of adding choroid plexus cauterization to the ETV for that particular child. In general, my default for infant ETV is that I would add CPC and then carve out certain cases where I might avoid CPC because there are risks associated with it where I think it may not add much. And the case that I just showed you for the data showing the older infants with pure aqueductal stenosis might be one such group. So here's an example of a baby who was born premature, 28 plus 5 at IVH. We inserted an Abhaya reservoir at 33 weeks. And now the baby's at 41 weeks, is big enough for shunt treatment, but continues to need Abhaya reservoir tapping. And what do you do here? And here's the MRI. And, you know, so as you consider, and I would say this for every case, I do at least consider endoscopy. And in many cases, I just write it off right away. But I think as you're considering treatment, you should always at least think about the role of endoscopy. Here, obviously, the factors against endoscopy are this is a very young child, just basically term age. They have a poor type of etiology, preemie IVH. What's favorable is, you know, this anatomy looks tempting. This child's got a pure aqueduct, has aqueductal stenosis, which is a common pattern that we see in preemie IVH, even though they may also have that scarring and such in the prepontine and other cisterns. They often do have an aqueductal stenosis component as well. This child had the aqueductal stenosis and minimal prepontine adhesions. And so this was kind of tempting me, even though I realized this was not a good case because of the age and the etiology of the hydrocephalus. in cases like this where I'm kind of debating, am I doing something crazy here by even offering ETV? I went to some of my colleagues, both at Sick Kids and around North America, particularly within the Hydrocephalus Clinical Research Network, and asked them. And they thought sort of similar to what I did, which is that, yeah, shunt is the right thing to do here. I guess if you were ever going to consider not, or if you're ever going to consider ETV in a baby, this would be in a baby with preemie IVH, this would be the situation. But if that were the case, then I think I would have delayed the treatment and actually tapped the child longer to get them to a slightly older age before doing the ETV. Now, as it turns out, there were social circumstances that made the decision for me, because to go down the path of potential ETV here, recognizing that it's sort of a fringe type of maneuver, would require a very thorough discussion with the family. And they would have to have a very clear understanding of what you're offering, what's involved, what the risks are, and how that's weighed against what would be clearly the standard of care, which is shunt. And this situation was such that the family literally did not want to hear what I had to say about anything neurosurgical. Even when I talked about the Abhaya reservoir, they would literally cover their ears, not wanting to hear it. I had to write it down so I could acknowledge that they at least understood that. They knew that surgery had to be done. They just didn't want to hear about the risks and stuff. So anyway, so this was not a case where I was going to be able to have that type of discussion with the family. So we just ended up shunting. Now here's another case, a 5-month-old term baby, had meningitis and then developed post-meningitic hydrocephalus with very clear signs and symptoms needing treatment. And here you see the anatomy again looks quite favorable. There's an aqueductal stenosis. The floor looks good. The prepontine cistern looks good, but it's post-infectious, and that weighs against it, right? We know that post-infectious does quite poorly with endoscopic treatment, even though this MRI looks very tempting. So this is one that I was very much on the fence about, and the family was too. And so what did we do here? Well, fortunately, these days we can do this. We can randomize when you're on the fence about it, when there is equipoise. So I had this case reviewed by my colleagues, and then through the expert panel associated with this randomized trial that we're running through the Hydrocephalus Clinical Research Network, that is comparing ETV CPC to ventriculoperitoneal shunt. It's enrolling all infants with newly diagnosed hydrocephalus who are under 2 years of age. We're excluding preemie IVH, unfortunately, and that was something that came through in the NIH review process. The reviewers felt that including this population would sort of muddy the waters a bit, which I understand the rationale for that, although I still wish we had included that group in this. But in any case, these are the children that are involved. We're going to follow these children until age 5 with cognitive, quality of life imaging, and CSF biomarkers outcomes. So quite aside from the primary study intervention question of ETV versus shunt, I think there's going to be a lot of superb longitudinal data on a large cohort of infant hydrocephalus. So far, we've randomized 30 patients to date. So this patient that I just told you about, we submitted it to an expert panel that's associated with this trial who reviewed it. They also felt that the child could be good for both procedures and that neither was superior. And the family agreed to randomization. We did, the child was randomized and was randomized to ETV CPC, which is what we did. And the child early days has done well so far. I want to mention about, before leaving the topic of ETV in infants, about some technical considerations here. And some of this will be very familiar to you, but others may be a little bit different than what you're used to doing. But I think this is crucial to pay attention to some of these technical nuances, because one of my big fears with this procedure is CSF leak. And because there's a high rate of failure, so you can expect that even after you treat them, there's going to be a substantial population that will have continually raised ICP and really test the integrity of your wound closure. So what I do, for these, I don't make a linear incision, which I would for some for some older children with hydrocephalus and ETV. Instead, I use a curvilinear incision that's similar to a shunt incision that I base laterally to avoid having the suture line over the durotomy. And then I lift a separate pericranial flap that's based medially, so opposite to the scalp flap. And then that's laid back at the end to provide another barrier to CSF. And also you can sometimes use that to supplement the dural closure if the dura doesn't come together properly. If the coronal suture is not widely splayed, then I don't make a burr hole to access the dura. Instead, I lift a small mini craniotomy that's hinged on the coronal suture. So you just make a very tiny burr hole either a couple of centimeters in front or behind the suture, your choice, and then lift sort of a U-shaped bone flap that's based on the suture, and just keep it attached to the suture and just flap it away while you're doing the ETV, and then flap it back down at the end. We do a linear dural opening that's coronally oriented, and paying great attention to not cauterize the dura, because you don't want the shrinkage of the dura, because you want to have it as robust as possible when you close. I very much try to avoid putting an EVD in these cases. So unless there is significant intraoperative bleeding, I really avoid an EVD, mostly because it's another avenue for leakage of CSF. At the end of the case, I plug the cortical tract with a T-shaped plug of DuraGen. I don't use gel foam here because sometimes the way that disintegrates can leave debris that can clog the ETV. And then a watertight dural closure with running, locking PDS suture, and incorporating pericranium into that closure if needed to get that watertight. Then you suture the bone flap back down, and then do a meticulous 2-layer scalp closure. Or sometimes if the galea is very poor and your sutures seem to be just tearing through it, then what I use is a single layer running vertical mattress suture with Prolene. And using this technique, I've for the past 12, 15 years or so, I've certainly had a number of infants who failed their ETVs, but none who failed because of a CSF leak. And that's important. I think it's very frustrating and disappointing when you have to declare a failure of this procedure because of a leak. And then it's also important how you follow them post-operatively, because you have to have I think, a holistic approach to determining whether the procedure is working or not, and be patient about it. So post-operatively, what you often find is that you will see a sunken fontanelle early, certainly within the first day or so, but it often fills back up within the first 24, 48 hours. And I warn parents about that because they're so happy right after surgery that everything's sunken. I say, it's going to fill back up, and usually it does. But in the cases that ultimately do succeed, it usually settles back down after a week or two, or sometimes longer, sometimes up to 3 weeks. And then after that, you need to be patient and monitor with multiple metrics over time before you declare a failure. So, you look at the standard metrics that we look at, head circumference, fontanelle, the clinical status overall, and finally the imaging, which is often the least useful actually for determining failure in these cases, because as we know, we don't see a huge change in ventricle size, and even having the presence of a flow void doesn't necessarily mean that the procedure is physiologically sufficient for the child. So we'll leave infants now and talk about ETV in older children. And here I want to get into the limitations of the ETV success score, at least one of them. So this is a 10-year-old boy who had a significant developmental delay, and then presented because he was incidentally found to have papilledema. And then in retrospect, the parents were saying, maybe he's a little bit more fatigued and sleepy, but generally doing well and behaving as he usually would, eating fine and such. But in the background, he also has significant medical comorbidities, the most significant of which is end-stage renal failure. And he's scheduled to undergo peritoneal dialysis and eventually renal transplant. So you're getting the picture of this kid now. And this is the MRI. And as I looked at this, again, looks tempting for ETV. Just the anatomy of the third ventricle here and the prepontine space looks okay. There may be a little scar there, but one that probably could be traversed. Question is what the etiology of this hydrocephalus was, and I really wasn't sure. We looked very carefully with Fiesta imaging, and neither I nor the radiologist could convince ourselves that there was any sort of an outlet obstruction at the fourth ventricle. So I wasn't sure what the etiology of this actually was. And so when you do the ETV success score for this, child clearly gets 50 for age and 10 for having no shunt. But they, by default, go into the best etiology category because they're an other etiology. And this is one of the problems I have with the ETV success score. Because in many cases, that is not an adequate reflection of what's really going on here. And you can just get that gestalt that this is a case that looks like a non-obstructive type of hydrocephalus. And yes, the ETV success score says this should be a 90, but it doesn't feel like a 90 to me. And obviously it's very unscientific, but it just didn't feel like a 90 to me. And I explained that to the family when we talked about the option here of ETV or not. And what you need to understand is when you have a score like this, or any sort of prediction score that's developed for whatever condition it is, it's only good at predicting the types of cases that were in the development of the model itself. And so this other etiology category just represents a miscellaneous category that didn't fit into one of the other discrete groups, but was a group of patients who, for some reason, a surgeon thought an ETV was worth trying. So it's already a more favorable group. Whatever etiology it is, somebody thought this was worth trying. That's why they were in the ETV database, and that's why we were able to use that data for the ETV success score. So just keep that in mind when you're using this type of a prediction score or any type of a prediction score out there, particularly when you have loose categories like this, other etiology. So, when we go back to this decision-making, it doesn't look like there's an obstructive lesion here, which doesn't have to be the case for ETV, but, I'd like to see that, but we didn't see that here. But the anatomy was good, as I explained. The patient was hyposymptomatic, right? Just had mild papilledema, vision was not being compromised as yet, and was otherwise pretty well. This questionable fatigue and sleepiness, which to my mind meant that as I weigh these two procedures, we have time, that we could do an ETV, and if after a few months we decide it's a failure, it's not the end of the world. We haven't lost. The kid shouldn't go blind. The kid shouldn't, go into coma or extremis or something. It should be okay. So we have time. And there's the factor of the medical issues there, which under these circumstances might make you more tolerating of a higher risk of failure or complications from an ETV relative to shunt. And then the other factor that was here that I didn't put down is in distinction to the first case that I presented. This family was very well aware of hydrocephalus and hydrocephalus treatment because they happened to have had an older child with hydrocephalus, unrelated cause and such. And having managed that child through many shunt complications and stuff over many years, they were well aware of what was involved with that. And I could have and did have a very detailed discussion with them about the role of ETV here. And again, this was a case that I ran by my colleagues to see what they thought. And they also thought, again, shunt would be the default choice, but under the circumstances that we're looking at with these medical issues, they thought it was reasonable to consider ETV. And so after having had a very detailed discussion with the family, they opted for the ETV. We went ahead and did that. And again, the child's doing quite well with this. Now, final point about ETV, I do mention this in some of my talks, and it's about the psychology of shunt versus ETV and how we think about this. And, I lecture, I participate in lectures that one of the psychologists runs on decision-making. And she has me there because, to her grad students, because even though it's not surgical decision-making, she's interested in how surgeons think about stuff and what goes into their decision-making process. And what I learned from that is, about acknowledging the biases that we bring into our decision-making. And I think we do all have an inherent bias towards ETV when we're considering ETV versus shunt. And first, of course, is that it's inherently just a more appealing operation to us, right? All else being equal, would you rather spend the morning doing an ETV or a shunt? And at least 90% would say shunt, and 10% would say they'd rather be golfing or something. But would say ETV, but it's a more elegant procedure. It is a more aesthetically pleasing procedure, I think, for us. I don't have to explain to you why we like that operation. We do. So that goes in. That's somewhere in our thinking about this procedure. The other point about this is that when we think about shunt, often what viscerally comes to us is our recollections of these shunt disaster patients that we all have in our practice. And we remember them well. They've been in hospital for weeks or months with just complication after complication. And that's a visceral reaction we have when we talk about shunts. ETV disaster patients, we don't have many of those. In fact, unless you've had a catastrophic intraoperative complication from an ETV, which happens to very good surgeons, but is still rare, then you don't really think much about ETV disasters. And, partly almost exclusively, it's because all the ETVs that fail eventually get salvaged by shunt, and then they go on to become shunt disasters. I mean, if we lived in a world where once you did a first ETV, every failure meant that you had to redo that ETV, whether it's in the middle of the night or whenever, you'd probably learn to hate ETVs pretty soon. But that doesn't happen, right? When we start with our cases, particularly with infant hydrocephalus, a small portion of them undergo ETV, right? We still do mostly shunt, but a small portion undergo ETV. And yes, some of them are successful, but it's a relatively small proportion of this whole population. A lot of them fail, and then they go on to shunt. And with shunt, some of them obviously will fail, and some proportion will become these shunt disasters that we carry around with us. But in fact, what we don't think about is that a lot of these patients are in fact doing very well with shunt and are successful. And proportionally, this is the largest group. But we overemphasize in our minds this disaster group and this success group. I only point this out to just make sure that as we make decisions about this, that we are explicit about the biases that we bring, because the inherent bias we have is that ETV is better than shunt. But the data, the real data from a patient perspective, does not bear that out. Okay, and I won't go over that here, but that's a whole other talk. And finally, this topic, totally unrelated to what I just talked about, but determining shunt independence. And I present this here because I suspect I'll get some criticisms from some of the other senior surgeons here for this, but I don't know, let's see. So this is a 10-year-old boy, just as one example, who had myelomeningocele, was shunted at birth, and had done well with the shunt, and then went on to have no revisions, but now presents with a primary abdominal process. So it's not a shunt infection primarily, but secondarily has infected the shunt. And while he's getting treated for the abdominal infection, we remove the shunt and place an EVD. And at this point, we make the decision to challenge him and determine whether he actually still needs the shunt or not. And here, I think a number of my colleagues would say this is not a wise thing to do in a 10-year-old with myelomeningocele, because I think we're taught quite rightly that that many kids with hydrocephalus, particularly those with myelomeningocele, have quite a brittle form of hydrocephalus, and when their shunts block, it can be catastrophic. And we've also seen those. I think every one of us has in our practice a child who's come in comatose or dead after a shunt block that happened quite acutely. So I'm well aware of that. And so I do want to point out that I go through a process that I think is quite thoughtful about determining who I would consider challenging for shunt dependence in older children. And I want to point out very clearly, I only do this when the opportunity presents. I don't seek out kids who are doing perfectly well walking around and, hey, why don't you come in and let's figure out if you need your shunt or not. I'm talking about situations where for other reasons you've had to externalize the shunt or put in an EVD. And in those cases where they meet this other criteria that I've listed here, then I would certainly challenge them and see whether they actually still need their shunt. So if they have to be asymptomatic, no papilledema, the shunt should have been inserted when they were an infant, and they should not have needed any shunt revision since. On rare occasion, I have considered it acceptable if they've had some very early infancy shunt revisions, but none since then. So I certainly wouldn't consider doing this in a 10-year-old who had a symptomatic shunt obstruction when they were 5, for example. The child needs to be reliable so that they can articulate their symptoms clearly and early enough. Parents need to be reliable so that they will bring the child in for appropriate follow-up and bring them in urgently when needed, and that they live within a reasonable close proximity to the hospital. And so this child, this was his baseline imaging with his shunt in place. This is what he looked like, very, very tiny ventricles. And we clamped his EVD for a week, and this is what he looked like. And right away, obviously that's a little concerning. Vents have gone up. So clearly he was draining through that shunt, but he was perfectly fine symptomatically. And so we ultimately removed his hardware. And this was him 1 week after EVD removal. So as you can see, we kept him in hospital for quite some time, even after all his hardware was removed, and he was clinically perfectly well. And then we followed him very closely every few weeks initially. And then I expanded that out, but with MRI, routine ophthalmology, and neuropsychological follow-up. 8 years later, his imaging has been stable, and he continues to do well. Now, can he become shunt dependent again? Sure. And I've seen people become shunt dependent many years later. So yes, and so he'll continue to need close follow-up. But this is a case where I think we've done him a favor by, at least for a period of time in his life, substantial portion of his time in life, he has not had a shunt. And does not seem to be shunt dependent at this time, but we don't know what the future holds. And I'll look forward to hearing what others have to say about that.